Yeah, for paper 1, morning shift, a medicine recall. First, a 60-year-old female with features of heart failure like biobasal Krebs, S3 present, breathlessness, and EF was reduced, reduced ejection fraction, HFrEF. Which of the following beta blocker can reduce the mortality? Three beta blockers you should know with respect to HFrEF. One is cardioselective bisoprolol, next is carvedilol, and the next one will be metoprolol. So bisoprolol was given in the options, so that will be the right answer. Second question, patient with a diastolic murmur, JVP shows prominent or rapid Y descent. Diagnosis is bicuspid aortic valve with AR, constrictive pericarditis, RHD with MS. So let's see the difference between all the three. First see tamponade, and next is constrictive pericarditis, and next is aortic regurgitation. So in tamponade, the huge amount of fluid around the RV causes pan-diastolic resistance to the RV filling throughout the diastole. So there won't be any Y descent at all. Y descent is for right atrial emptying. Right atrium can't empty at all. Whereas in constrictive pericarditis, there is a thick pericarditic calcific shell which causes resistance only in the early diastole part. In mid and late diastole, there will be gush of fluid from the RA to the RV causing this diastolic murmur as well as prominent or rapid Y descent. Whereas in AR also you can tell there is a diastolic murmur, but there is no problem with the RV filling at all. So there is no need for any change in the Y descent. So the answer is obviously chronic constrictive pericarditis. Next, ECG was given and a patient of hypertension and CKD with tiredness. ECG shows tall tinted T waves, so the answer should be hyperkalemia. Tall T wave definition, more than 40% of the height of preceding QRS complex. And then you should see the symmetry. If it is asymmetric, then it's a normal variant, no need to do anything there. If it is symmetric, dividing it into two equal halves, then it can be due to hyperkalemia or myocardial infarction. How to differentiate it is by seeing the size of the T wave and tip. If the base is broad and not pointed tip, then it will point towards MI. If the base is narrow base and a pointed tip, then it is tall tinted T waves of hyperkalemia. And QT interval will be prolonged in MI and decreased in hyperkalemia. And cardiac markers will be raised in MI, whereas negative in hyperkalemia. Next question, a 29-year-old athlete suddenly collapsed during sport activity. Autopsy was done and cardiac biopsy showed myocyte disarray. Diagnosis is. So this is nothing but hypertrophic obstructive cardiomyopathy. It is nothing but as asymmetric septal hypertrophy, that is ASH, causing dynamic left ventricular outflow tract obstruction. Okay, this causes the murmur. This murmur increases by Valsalva activity, whereas all the other murmurs decreases on Valsalva. There is HOCM is an exception. After Valsalva, the left-sided filling will be reduced. Okay, left atrium and left ventricular filling will be decreased. This will increase the murmur and increase the obstruction and murmur in HOCM. In mitral valve prolapse also, this murmur of mitral valve prolapse also increases post Valsalva. Okay. Yes. Next is a hypertensive patient having renal colic, calculi. Best treatment is drug of choice is thiazide or loop diuretic. The answer is thiazide, because what does thiazide do is it acts on the distal convoluted tubule. So in distal DCT, this is the cell having sodium chloride symporter, and there are sodium potassium ATPases and sodium calcium exchanger on the other side of the cell, and this is the lumen. This thiazide inhibits this sodium chloride symporter. So what will happen? There will be low sodium in the cell, and there is sodium potassium ATPases pumping out the sodium. So to maintain the sodium levels, sodium will start coming in through the sodium calcium exchanger. So calcium will be trying to get reabsorbed from the lumen, and it will be exported out. So that's why in renal calculi, it's best to give thiazide, and the MRI image was given. Here, if you see, there is no dissection flap, no false lumen can be seen, so it's not aortic dissection. Or there is no narrowing seen post the origin of three main vessels, no coarctation of aorta. And if you see there is an aneurysm, saccular aneurysm near the arch of aorta. So it is nothing but saccular aneurysm near the arch of aorta. Next, why a patient has aortic stenosis as more fatigue compared with AR? See, in AS is nothing but a pressure overload condition where there is a stenotic aortic valve increasing the afterload and there is a pressure overload causing left ventricular hypertrophy. So this hypertrophied myocardium will demand more oxygen, so there will be more demand of oxygen compared with low oxygen supply. This causes angina in aortic stenosis patients. Whereas in AR, due to large amount of blood regurgitating back into the ventricle causes left ventricular hypertrophy and as well as dilatation simultaneously. So it's a volume overload condition. So this is nothing but increased in the preload, okay, whereas AS is increase in afterload. So as per Laplace law, the increase in stretch of the myocardium will increase its contraction. So AR is usually well compensated in the initial phases. So it doesn't cause fatigue or this thing. So if you see the options, pressure overload increases myocardial demand, yes, than oxygen volume overload. Yes, it's right. Volume overload increases myocardial demand more than pressure overload. It's a false statement. AS does not cause pressure overload. It is a pressure overload condition. And preload increases myocardial oxygen demand more than afterload. No, it is the afterload which increases myocardial demand than preload. Next, respiratory system. 53-year-old male patient, known case of COPD on mechanical ventilation, suddenly developed hypoxia, reduced or absent breath tones on left hemithorax with increased peak inspiratory pressure. This peak inspiratory pressure can cause bulla or any alveoli to rupture in a already hyperinflated lung of COPD, causing pneumothorax, and the reduced or absent breath tones always suggests that it is going towards pneumothorax and the patient is going for hypoxia. The answer is pneumothorax. And one more question was asked on pneumothorax. Chest X-ray finding of pneumothorax was given and patient was having breathlessness. So they are also given like on auscultation, what is the finding? It will be absent breath sounds. Next question, a 44-year-old male with cough, chest X-ray says to of pleural effusion, pleural fluid protein by serum protein was found to be 0.6. Diagnosis is. So the options were three transudative options were there: cardiac failure, nephrotic syndrome, and one exudative which was TB. So what is the criteria used there? It is Light's criteria, which tells that pleural fluid protein by serum protein, if you see the ratio, if it is more than 0.5, or pleural fluid LDH by serum LDH ratio if it is more than 0.6, or pleural fluid LDH if it is more than 2/3 of serum LDH, upper limit normal. If one of the three is positive, then we tell it is exudative pleural effusion. So here it was 0.6. So answer should be tuberculosis, pleural tuberculosis. Next question, a 45-year-old patient having ptosis and having a muscle weakness that improves on rest. And they are given it to be myasthenia gravis in the question also. And they asked like, now the patient is complaining of dysphagia and engorged veins over the thorax. CT was suggestive of some anterior mediastinal mass lesion. So the diagnosis they have asked, nothing but it is thymoma causing myasthenia gravis, as well as this compressing the esophagus resulting in dysphagia, as well as compressing the SVC causing engorged veins over the thorax. So diagnosis thymoma. Next question, indication for shorter course bedaquiline regimen is. So here we discussed this shorter oral bedaquiline regimen, which comprises of bedaquiline, fluoroquinolone and clofazimine ZE-ETO-H. High dose isoniazid will be used. Indications, if you see, it is MDR TB or rifampicin resistant tuberculosis, and it should be sensitive to fluoroquinolone because we are using fluoroquinolone levofloxacin. And high dose isoniazid we are using because two genes are responsible for isoniazid mutation like CATG or INHJ. Either one of the gene mutation is there, then we can go for this short oral bedaquiline regimen. So rifampicin resistance, I think they have asked in question. It is, the answer is rifampicin resistant tuberculosis. Next question on bronchial asthma, they asked baseline FEV1 was 70%, which increased to 83% after bronchodilator nebulization. He was already on only MDI albuterol, and he had symptoms at least 2 times a week, and he is waking up at night due to the symptoms. What do you do? So these are the steps in asthma you should be knowing. First is step 1 and 2 if the symptoms is less than 4 to 5 days a week. Steps 3 and 4 if it is almost daily symptoms or patient has night awakening. In step 3 there will be a normal PFT, and in step 4 there will be deranged PFT. And if it's refractory, then it's step 5. In step 1 you should be using only reliever therapy, SOS. In step 3 you should be using MART, meaning you should be daily using the patient with low dose ICS with LABA, which is a beta agonist. So here you should be increasing, adding a patient with a low dose inhaled corticosteroid therapy like fluticasone. Next, a 30 weeks pregnant patient is diagnosed with DVT. Most appropriate treatment, it is nothing but low molecular weight heparin, drug of choice for DVT in pregnancy. Next question, one-liner reversal agent for vecuronium, it is nothing but Sugamadex. Next is aprepitant mechanism of action, which is nothing but neurokinin 1 receptor agonist, and this is used in the treatment of chemotherapy induced vomiting. Next, scleroderma patient with breathlessness on exertion, right heart cath shows mean pulmonary artery pressure of 35. So MPAP more than 20 millimeter mercury in right heart catheterization is diagnostic of pulmonary arterial hypertension. True statement is CCB is first line for all patients, lung transplant is best treatment, lifestyle changes needed, and endothelin receptor antagonist improves symptoms. See, this is the ERS ESC guidelines, latest guidelines for pulmonary hypertension. First, always check for the vasoreactivity testing. Next, if the patient, if he is with cardiopulmonary comorbidities, then the initial therapy should be a monotherapy with either PDE5 inhibitor like sildenafil, tadalafil, or endothelin receptor antagonist like bosentan or ambrisentan. If it is without any comorbidities, cardiopulmonary comorbidities, then we will start with either PDE5 inhibitor, or if there is a high risk strata, then we'll go for endothelin receptor antagonist with PDE5 with prostacyclin agonist. So calcium channel blockers are not the first line in all. Next thing is ERA actually improves symptoms in pulmonary arterial hypertension. The answer should be D. Next, a diabetic patient, type 1 diabetes, stage 3 beta cell destruction. What is the features? See, diabetes mellitus type 1 always autoimmune, and in stage 1 it will be a normoglycemic without symptoms. Stage 2 it will be dysglycemic without symptoms. Stage 3 it will be dysglycemic with symptoms. So the answer is option 3. Next, ALL treatment they have asked. They have given clinical features like purpura, cervical lymphadenopathy, hepatosplenomegaly, and it is a 7-year-old child also. TLC having 50,000. Next question on thrombocytopenia and anemia. Like testing of ALL, and treatment is nothing but vincristine as well as raised gene mutation they have asked, which is nothing but PML rara. Next, headache with neck stiffness patient. CT was suggestive of blood in the sylvian fissures as well as in the basal cisterns. It's nothing but subarachnoid hemorrhage. Next, Horner syndrome, ptosis due to involvement of what muscle? Muller's muscle, because it has sympathetic innervation. Horner syndrome is a disorder of sympathetic activation. Next, multiple myeloma treatment drug which causes reactivation of herpes zoster, which is nothing but bortezomib. It is a proteasome inhibitor, and always with bortezomib we give zoster antiviral prophylaxis. Next, a 57-year-old patient having polyuria and weight loss. Bone marrow biopsy showed foam cells with immunoglobulins. Nothing but diagnosis multiple myeloma. Next, heart failure in rheumatic fever is due to MR-MS myocarditis. See, myocardium has a contractile part as well as specialized segment. Specialized is nothing but conduction fibers like AV node. So this, if it is affected, it causes increased PR interval, which is a minor criteria in ARF. And contractile myocardium, if it is destroyed, it will cause LV systolic dysfunction and heart failure. And always remember, acute rheumatic fever with MR, it is usually well compensated. It doesn't cause heart failure. And MS takes almost 1 to 2 decades to develop. So it is not also the answer. The answer is myocarditis. It needs steroids also for treatment. Next, one more question. 18-year-old female with fever, polyarthritis and pansystolic murmur at the apex due to mitral regurgitation. Diagnosis they have asked, it's nothing but acute rheumatic fever. Drug of choice for hypothyroid in pregnancy, it is nothing but propylthiouracil. Next is mixed malarial infection. They have asked a patient from Rajasthan and 18-year-old and weighed 50 kgs. Day 2 drug treatment they have asked. Vivax with falciparum malarial infection. See, primaquine should be giving 0.5 mg per kg, 50 kgs, so it will be 2.5 mg, 6 tablets, and artesunate 50 mg should be given. This as per National Malarial Elimination Program. Last, a patient presents with perioral pigmentation, hypotension, BP 90/60 and hyponatremia, sodium 125 and hyperkalemia. Diagnosis they have asked. So this is the adrenal cortex which is stimulated by the ACTH to secrete glucocorticoids, and mineralocorticoids is not under ACTH control. Next is sex steroids. So all three are secreted by the adrenal cortex. So glucocorticoids increases the glucose levels as well as sodium water retention. Mineralocorticoids causes sodium water retention with potassium and proton excretion, and sex steroids are androgens. So if there is primary adrenal insufficiency, the adrenal cortex is damaged, leading to cortisol deficiency causing hypoglycemia and decrease in mineralocorticoids. So hyponatremia as well as decreased sodium water retention will cause hypotension, and potassium is not excreted, so hyperkalemia, and proton is not excreted, it causes normal anion gap metabolic acidosis. And since glucocorticoid release is under the control of ACTH, due to negative feedback, ACTH will increase, that will stimulate the melanocytes to secrete more melanin, and this causes perioral hyperpigmentation. Mucosal hyperpigmentation will be seen as a classical part of it. This is nothing but primary adrenal insufficiency. Thank you. If you have any comments or any difference in opinions, you can comment it in the comment section. Thank you.